Delegate Price,
Here.
Delegate Willett,
Here.
Delegate Bell, Delegate Austin,
Present.
Delegate Brewer, Delegate Hanger or Senator Hanger,
Here.
Senator Barker, Senator Favola, Senator Mason,
Here.
Senator Deeds.
Here.
Mr. Chair, you have a quorum.
Okay, with that, Sarah, I think what we talked about, this isn't on the agenda, but you were going to just provide a little information about the process that's going on right now. We're receiving applicants for executive director, and I think you said there were 7 applicants received so far, and the applications are going to be received through Friday of this week. Is that correct?
That is correct. The ad closes Friday of this week, and at that point, we will move forward with sorting out the interview and selection process, and that was discussed at the last meeting. So we have a general outline as to how that's going to go, and it should move somewhat quickly.
Okay, we don't have any information to share with the other members of the commission right now about the applicants. We don't know who they are or where they come from. Is that correct?
Yes, that is correct. The materials are still being collected through the DLS, HR, and online application system. And once it closes, that material will be available to the executive committee to begin the selection process.
Okay, very good. Okay, well then the first thing on the agenda is a presentation by Debbie Oswalt, who's the executive director of the Virginia Healthcare Foundation. She's going to provide an assessment of Virginia's licensed behavioral health workforce. You know, we've known that the workforce issues are huge and they had a major impact on the hospitals this summer, but they were, and while we've gotten over that hump to some extent, there's still an issue. And so we look forward to hearing from you, Debbie. Thanks for being here.
Thank you, Senator Deeds. Hello, everyone. So I just want to remind you, for those of you who don't know, the Virginia Healthcare Foundation was actually initiated by the General Assembly and its Joint Commission on Healthcare 29 years ago as a public-private partnership with the mission of increasing access to primary health care for uninsured and medically underserved Virginians. So thank you for your support and partnership over the years. And I just want to start by thanking you also for all of the work that this commission has devoted over since really the years since it was created to increasing timely availability of mental health services. I know the problem can seem very overwhelming, but I do think it's important to recognize the tremendous progress we've made in Virginia as a result of all of your work. And I actually am here today to contribute to the further progress and forward momentum by sharing the results of the assessment that we just have been doing over the past 4 or 5 months of Virginia's behavioral health workforce. And first slide. So essentially, I'm going to show you the extent of the current shortage of licensed behavioral health professionals, a not so rosy look at the pipeline for producing more, and suggest some solutions. Next slide. I think it's important to provide some context for the data I'm going to share. You know, here in Virginia, we are accustomed to top ratings on national scorecards, best state for business, best state for education, that kind of thing. Unfortunately, that is not the case for where Virginia is ranked for availability of behavioral health services. We're actually 39th in the country in terms of the number of behavioral health professionals per 100,000 population. The consequences of that are pretty clear and reflected in the community health needs assessments that Virginia's nonprofit hospitals have to put forth and conduct every 3 years, and where behavioral access to behavioral health services is always one of the top concerns. At the Healthcare Foundation, we've been working to increase access to basic mental health services, primarily in the healthcare safety net of Virginia. and some community nonprofits for the past 13 years. The pandemic and its consequences have led us to put special emphasis on making basic mental health services more available. So we did the assessment so we could figure out where and how to target our limited resources. Next slide. So the 5 licensed behavioral health professions are the ones that we focused on, and here they are listed for you. Next slide. The first thing to note is that along with all of us, I feel this myself, a significant portion of Virginia's behavioral health workforce is aging. And so the data that you see here is from the Virginia Department of Health Professions, and you can see the percent of the workforce for each of these professions that is age 55 and above. So significant portions are within 10 years or less of retirement age. And, you know, even those percentages that are in the 30%, while they aren't as dramatic as the 61% number for psychiatrists, are still way too high. I mean, you would normally, if everything were just right, you'd be probably seeing about 23% if everything was evenly staggered across the decades for people. Obviously, the most alarming is the shortage. We already have a shortage of psychiatrists. We're about to have a really big one, and also psychiatric nurse practitioners. And this is all based on a workforce that was inadequate before the pandemic and is just sorely lacking at this point. Next slide. The other thing is there's a significant lack of diversity in the current behavioral health workforce. And this data shows you the percent of the race and ethnicity of each the percent of each race and ethnicity within Virginia from the 2020 census, and then shows you the percent of each of these 3 behavioral health professions. And so you can see we have a long way to go. It's important to address this issue because we know that effective therapy occurs when the behavioral health professional can relate to the patient's situation. And this is especially true when a patient's stressors and trauma are related to experiences related to their race and ethnicity. Now, we wanted to understand if there are some localities with a greater shortage of each of these behavioral health professionals than others. And we've prepared maps that I'm going to show you in a minute that show the number of each of the, we've done a map for each of the 5 behavioral health professionals practicing in each locality, so you'll be able to see. But before I show them to you, I thought it might be helpful, next slide, to just give you an overview of the data. And so the first line of this chart shows you the number of localities with none, with 0, no none of the behavioral health professionals listed. So 54 localities have no psychiatrist, for example. 51 have no psych NPs, etc. The second line shows you the number of localities with 1 FTE or less of licensed behavioral health professionals. And so the other thing that you should note is that we have 2 localities, Craig and Surrey counties, that have absolutely no licensed behavioral health professionals. And we have 2 more that have 1 or less FTEs. That would be Matthews and King and Queen counties. The most worrisome is that 35 localities have no behavioral health prescriber, and an additional 25 only have one. So that's the psychiatrist and the psych NPs. And so these are the same two professions with the highest percentage of those at or near retirement age. So, it's just a perfect storm coming at us. And so while it's true that primary care physicians can prescribe for behavioral health conditions, most of them have little or no training in psychopharmacology, and many feel uncomfortable venturing into this area. It's an older study, a study from 2012 that actually looked at the prescribing of primary care physicians for mental health conditions, and noted that over 50% of the prescriptions that they wrote were for less than the recommended dosage. So, and if you talk to most primary care providers, they will tell you, they would just as soon not have to prescribe for mental health conditions. Now, next slide. The following slides show the number of those, of each of these professions practicing in each locality. And what you want to look for here are the localities with the stripes. Those are the localities that have 0 of the particular type of behavioral health professional. And then the darker the color, like that pretty dark blue, is actually a bad color because that is where there's only one. And so you can see the legend. So, and the other thing I'll just say is, you'll note, and probably isn't a surprise, Fairfax County, for all of these, has way more, 2 and 3 times more of the type of behavioral health professional than any other locality. So here you see the data regarding the psychiatrists in a map form. Next slide. Here you see the data regarding psychiatric nurse practitioners. Again, the stripes and the dark blue, we shouldn't be feeling so good about. Next slide. Here is your map showing licensed clinical psychologists in Virginia. Next slide. Here's the one showing licensed clinical social workers in Virginia. Next slide. And here is the one showing licensed professional counselors in Virginia, just to give you a feel for things. Now, when there are discussions about the shortages of of all kinds of health professionals in different areas, many automatically think that telehealth can address the problem. And in fact, telehealth was a significant help, has been a significant help during the pandemic, and has enabled many people to receive care. I was listening to a webinar a few weeks ago, and one of the national consulting groups documented the use of telemental health grew by 25% during the pandemic, and that telehealth was used for behavioral health services more than for any medical specialty. So, it definitely can be very helpful. It's all good.
And recommendation number 3 is to introduce a budget amendment.
It's all good, but telehealth is not a panacea. One obstacle, next slide, is the lack of broadband connectivity. This map shows you the mental health professional shortage areas in Virginia, where the people living in these localities where a significant portion of the people living in these localities reported on the recent census that they do not have broadband service. So I know that, we have a goal of getting broadband coverage everywhere, and that that's been accelerated with the resources from the federal COVID money. And so, we have a lot to look forward to in the future, but it will take a while. And this is a problem that exists right now and likely will for the next several years. And so while it's likely that some of the people in these shortage areas can go to other localities, to get services, next slide, it's also clear that there are consequences. Wait, there should be another slide. Can you go back one? There. No. There, that one. So it's also clear, thank you, that there are consequences to not having local behavioral health professionals, because overall, when you look at the data for key behavioral health indicators, the Virginia mental health professional shortage areas have much poorer outcomes on those indicators than localities that are not mental health professional shortage areas. Next slide. Now, as the final element of this portion of the current picture, we also just looked at the demand for jobs for people for these in these professions. And we went on to Indeed.com and looked at listings for anywhere in the state of Virginia. And this is the number of postings. This is just as of a few weeks ago. So I don't think it's a surprise that the demand is very high. Next slide. The good news is that Virginia schools have a total of 40 master's or doctorate programs to prepare behavioral health professionals. And this slide shows you the number of each type, so that you can, and the number they graduate from the programs. Next slide. The bad news is that the schools are not producing enough to even maintain the current inadequate supply of behavioral health professionals. And so this shows you the current workforce by behavioral health profession, the number and percent that are nearing retirement age, and then the estimated number of graduates becoming licensed per year in Virginia. And this is taking a 5-year, this estimate is based on a 5-year average and pass rates on licensure exams. So clearly, we all have some work to do. Now, I think that it's definitely doable to fix this. I don't want everybody feeling all overwhelmed or anything. We just need to prioritize, dealing with this problem. And we do have some suggestions and some good news about, next slide, of things that, we can do. One of the things that we did as part of this behavioral health assessment was we didn't just look at data, we also interviewed some of the folks that train behavioral health professionals and educate them in the various schools in Virginia. We also interviewed representatives from the various associations that represent these professions, and we learned of several opportunities to make progress. One that is something that we learned is that when you're an MSW and you graduate with a master's in social work, in other words, or you graduate with a master's in counseling, you can't just go right and take a licensure exam and start practicing. You actually have to, our law requires that MSWs have 3,000 clinical hours that have supervision to them. That's required. And to become a licensed professional counselor, you have to have 3,400 hours. And so while some jobs, actually, you get hired as an MSW or a master's in counseling, right out of school. And you can, along with that job, they will give you the supervision that's required for getting licensure, that is not the norm. And so what happens is, and the cost of getting the supervision averages about $100 an hour. So that's a cost to become an LCSW of $10,000 total, and $20,000 total to become an LPC. And so what happens is many don't have the money to run this gauntlet, essentially. And so they never make it to licensure. And the data that we were able to collect show that an average of 193 MSWs and 202 counseling residents do not make it to licensure each year. And while there can be any number of factors behind this deficit or this paucity, I think it's very reasonable to attribute at least some of this drop-off to the high cost of paying for pre-licensure supervision. We may not have to produce nearly so many additional MSWs and Master of Counseling residents if we can help more people who already have gotten their masters pay for the required licensure supervision. So one thing that the General Assembly may want to consider is piloting a program where the state pays for those fees, at least, for some folks. And that would accelerate the licensure of some of these professionals who we need badly.
Debbie, can I bother?
Sure.
Do you have any idea how many people are out there that could stand for licensure if we were able to assist them with this with this money?
I don't have a count for you. It's, as with most things, it's complicated to figure it out. But what we have done is we've been talking with Commissioner Land and Secretary Carey about this. And actually, there is a budget amendment that's being considered for the governor's budget that would pilot this, that would add 100 new, that would pay the fee for 100 MSWs and 100 Masters in Counseling residents. And we could see how this works. And so we're hopeful that this can make its way successfully through the process and into the budget that you all finally pass, at the end of the next session.
Mr. Chair?
Yes, ma'am, Delegate
Yes.
Price.
Yes, thank you, Mr. Chair. Ms. Oswald, question about the budget amendment that you all are considering. Love the idea. Just wanted to see, is that going to be targeting some of those areas that you pointed out on the map that were the not so good colors? Because without that, we might be helping, areas that are already saturated become more saturated. Is there consideration being given to that part?
Yes, exactly. Great question. And I should have added that already. I'm glad you asked. And so we have suggested that the money be targeted to people of color so that we can start to make a dent in some of that diversity issue, and also to people who are practicing in those mental health professional shortage areas. That is definitely what we would look at first.
But Debbie, I would suggest that even if the governor doesn't include this and that in the package, that you keep that alive and you bring it back before us sometime before the end of the year.
Okay, thank you.
It's a good idea.
Thank you. Well, and what's really great about it too is that you could use one-time federal COVID money for this because it's a pilot. And so, and it's so related. I mean, all this demand for mental health services that has just skyrocketed is very related to the pandemic. And so, it even fits within the time frame that we've got to spend the COVID dollars. So anyway, hopefully this will be something that gets included. Now, another thing is, there are interstate compacts that are becoming more welcome, shall we say, by the regulated professions. And so in Virginia, you all just recently approved that the clinical psychologists, that Virginia would engage in a compact that the clinical psychologists have. That's only for telehealth purposes. It's not for, it doesn't give reciprocity of licensure, but it's a good start. And the licensed professional counselors nationally and the LCSWs nationally are also at various stages of developing interstate compacts. Just earlier today, I learned that the licensed professional counselors may be bringing an interstate compact to you for consideration in the coming session. And so this, and the good thing is that both the counselors and the LCSWs would have reciprocity in theirs, which I think is such a good thing. And so I encourage you, as they come before you, to act favorably upon them, because I do think that's something that can help open up our ability to pull in expertise in the profession from other states. The other thing is, we have got to have more psychiatric residencies, both in general psychiatry and child and adolescence. And this is something, I mean, when you think about the massive number of psychiatrists retiring, it's really frightening. Like, where are we going to get this help? And so the General Assembly has given money in the past to increase the number of psychiatric residencies in Virginia, but we have to do more. And this is something the Psychiatric Society of Virginia noted and made a request for in recent testimony to the Joint Commission on Healthcare. But, it's a coming calamity that we can see. And the other thing is, I just recently learned that, for some of these psychiatric residencies that we have funded, we don't, the majority of the people who go through them then leave Virginia. And so I just found that out. So I'm about ready to start trying to figure out why that is, so we can try to remedy that situation, because you got to have the two combined. We got to have the residencies, but we got to hold on to the people. And but we've got to have the residencies.
Mr. Chairman, Vivian Watts.
Yeah, Delegate
That's
Watts,
all
I
right.
apologize. I just had my mic off.
Right. Ms. Oswald, what are the requirements for a residency? Where would these be located typically?
So, to be honest with you, Delegate Watts, I have not focused a lot on the psychiatric residency programs because I didn't know this was going to be such a big problem. So I think there are 7 of them. I think they're all associated with medical schools in various places. I don't think you have one in Northern Virginia, because I remember that as a conversation at the Joint Commission on Healthcare. I can definitely follow up and get you the information, however.
Thank you.
And this is not a new issue. We've had some testimony about the psychiatric residency issue before, but we need to come up with a similar type pilot project if we can to increase the number of residencies.
Yeah, and then really, Virginia has done so well with the STEM initiative, right? I mean, there's nobody in Virginia, I would venture to say, who doesn't know about STEM, who hasn't had their consciousness raised about it. And you're seeing really great results in terms of more kids getting into STEM education and that kind of thing. And I think that's because the Commonwealth made it a priority, from a policy perspective, that we need this for the future workforce. Well, I would suggest that we need to make it a state policy priority to have a robust, supply, a robust supply of behavioral health professionals, and make recruitment, production, and retention a priority. And so it's just more of a bigger picture sort of philosophy with which we approach things. But everybody these days recognizes the important link between a person's mental health and their physical health and their ability to function. And we also, even though there is still stigma, for some, in terms of admitting to or needing mental health help, the younger population, there's really no stigma at all to that. And I think more and more people, especially because of the pandemic, are recognizing the value. And so here you have a time when there's more demand, I think somewhat less stigma. And so, and we don't have the people to be able to address the various issues. So, I think the good news is that while we have a problem, it's not insurmountable. There are clear pathways to progress. And I think it's going to take all of us working together. And this is where we could go to the next slide, to make the progress that we need to make. And we at the Healthcare Foundation are committed to working with you to get this done.
Thank you so much. Are there any additional questions for Deborah Oswald?
Mr. Chairman, Delegate Hope.
Delegate Hope.
Yeah, thank you, Mr. Chairman. Thank you, Debbie. This may be one of the most important presentations that we've had in this commission. I think this year we've spent a lot of time trying to deal with the bed crisis and the state hospital issue with the workforce. And I have to say, Debbie, your slides, your presentation, especially when you put the map of Virginia on the screen and show all the different gaps that we have, all these different positions, every single one of those holes provides services in our community. And if people can't get access to service, they go into crisis. A lot of people go into crisis. And that's why we have so many people on this back end desperately seeking hospital bed care, because they can't get the services in the community. And so this has got to be a focus in the future for the legislature, this commission, to make sure that we solve this workforce issue so people can get access to this important care so they avoid the crisis. That's just my comment, Mr. Chairman.
No, I thank you for that, and I agree with you 100%. The key to the hospital crisis is to keep people out of crisis. If we keep people out of crisis, we keep them out of the hospital, and we can't keep them out of crisis if we don't have the people to provide services. So this is an important presentation. Thank you so much. Are there any additional questions?
Mr. Chair.
Delegate Price.
Yes, so thank you, Ms. Oswald. I concur with Delegate Hope in that this was extremely important for us to hear, I think for anyone watching here. We also, Delegate Hope and I just came from another meeting about another subject with another workforce shortage. And I guess I'm just kind of hearing the ka-ching sound adding up. So I was wondering if you all have any information on what the federal level might be doing from a more national perspective. And if not, I know that might be putting you on the spot, but if there is a organization or a source that we can go to see, because I would love to also advocate for this on the federal level while we're trying to figure out budget priorities for the state level as well.
So, typically, money to increase workforce comes from HHS and specifically HRSA, the Health Resource Services Administration, and they often have different kinds of grants and that kind of thing, that are focused on various parts of the workforce. That is the big picture answer. And if I'd be happy to help you explore it further if you would like.
Thank you.
Sure.
Okay, thank you, Debbie. I think next on our agenda,
Oh, Mr. Chair, I'm sorry.
I apologize. I'm trying to Delegate Willett, I apologize.
Thank you, Mr. Debbie, just real quick, I'm going to echo what my colleagues just said. This is a critically important presentation, critically important data for us to have. For the group's benefit, Debbie and I actually both were just minutes ago attending a healthcare related summit on workforce, and so discussing a lot of these same issues. I was on the breakout group dealing with the interstate compacts, but several key takeaways are coming from that. So we'll see where all this goes. I just a quick question, because I just don't. I know I'm so familiar with so many mental health, behavioral health professionals, but the nurse practitioners. Tell me what they can do, just high level, because I'm trying to understand just the angle I'm coming at here. Is that a group? I know we're competing for psychiatrists, getting them to stay here, but I'm just curious with the nurse practitioners, which in other areas seem to be doing so much. How does that equate in the mental health area?
Yeah, that's a great question. So, psychiatric nurse practitioners have training. They can do they can diagnose, they can prescribe, they have psychopharmacological training, and so they can definitely do a good chunk of what psychiatrists can do. I don't know. They say the rule of thumb when you hear people talk about it is nurse practitioners on the medical side can typically do about 70% of what a primary care physician can do. I don't know, honestly, if that would be a same kind of ratio to think about for psych NPs. But I do know they can certainly, our focus at the Healthcare Foundation is on basic mental health conditions, depression, anxiety, panic disorder, that kind of thing. The state system deals with the other end of the continuum, as you know, and seriously mentally ill, emergency kinds of cases. But, psych NPs can definitely, handle that whole basic that whole basic mental health services side of things. And frankly, that's where you have the greatest number of Virginians, who are in need of mental health services. And it's less expensive, and it certainly does help prevent, as some of you have mentioned. I should say, at the Healthcare Foundation, we are big fans of psychiatric nurse practitioners and have a scholarship program that we've had for a number of years now, where we pay full freight for someone who's a nurse practitioner to go back to school and get trained as a psych NP. And we have given out 39 of those scholarships and over the past several years. And our goal is that at least 50% of them go to people of color, and we have fulfilled that goal. And so, and then in return, we require them to work for 2 years in the healthcare safety net as a psych NP, or if there are no jobs in the health safety net, then in a CSB or other public, mental health capacity. And so psych NPs can do a lot. I'm just uncomfortable saying exactly how much.
Yeah, Debbie, isn't it true that the majority of psychotropic medications nationally are prescribed by general practitioners?
Yes, it is true. And then there's that data point that I gave you. It's an old one. It's 2012, but that from that study that showed that 50%, at least 50% of what they prescribed was below recommended dosage.
Right.
Follow-up question, Mr. Chairman.
Delegate Watts.
Forgive me if I missed this. Do nurse practitioners have prescribing authority?
Oh, yeah,
Thank
they
you.
sure do. Yep.
Are there other questions for Debbie Oswald? Thank you so much for this important presentation. It's
Thank
something we've needed to hear for a while, I think.
Thank you.
Okay, next on our agenda is Jennifer Wicker. Jennifer from the Hospital Association is going to give us an update on the role of community hospitals and the mental health, meeting the mental health needs of our many Virginians and taking as patients people who are in crisis. Jennifer.
Good afternoon, Mr. Chairman and members of the commission. I am Jennifer Wicker with the Virginia Hospital and Healthcare Association, and I truly appreciate the opportunity to come before you all today and share a little bit of what our hospital members are seeing within their facilities. So today I'm going to focus on 4 items. I'm going to talk briefly about the impact of COVID-19 on behavioral health generally. I'm going to talk about behavioral health inpatient volumes at the community hospitals as well as the state hospitals, and talk about the current state of Virginia's behavioral health system, which we all know is in a pretty tough spot right now, as well as talk about opportunities for the future. So since March of 2020, when the COVID-19 pandemic began, our hospital members have been at the center of addressing the pandemic and being part of the response here in Virginia. And as it relates to behavioral health specifically, as Ms. Oswald talked about, there are significant issues around adequate behavioral health workforce. And going into the pandemic, we were already in trouble. And the pandemic has absolutely exacerbated the workforce shortages. As a result of some of the workforce shortages and the pandemic generally, there were behavioral health services that were taken offline, during the height of the pandemic, including outpatient services, and some of those services have not been restored. And so there is a decrease in the amount of community-based services that individuals can access in order to prevent a behavioral health crisis. And in addition, on the inpatient side, there have been situations in which private hospitals have had to reduce their bed availability for quarantining purposes and to ensure isolation and COVID-19 protocols. During last year, when we had our stay-at-home order and there was significant isolation for individuals, there was lack of treatment that people were receiving, lack of access to medication in a timely fashion. And as people have started to attempt to get back to a normal life, we're seeing that individuals who are coming into the emergency department are coming with a higher acuity and a greater need in terms of the services and treatment that's required to stabilize them. As a result of that, that is increasing the length of stay for many of our inpatient stays. And when you have lengths of stay that are extended, that is actually, again, decreasing the availability of beds and the turnover that could happen when you have a shorter length of stay. Unfortunately, we have seen a significant increase in emergency department wait times. And I'll provide a little bit more information related to that. But we'll say quickly that in terms of the emergency department wait times, we're seeing that across the board for voluntary patients as well as involuntary patients. So quickly, to kind of get us all on the same page, during a lot of conversations that we have around behavioral health, there is a significant focus on the patients who are involuntarily committed, or what we've referred to as TDOs. And those are individuals who, as a result of their behavioral health diagnosis, are determined to be a threat to themselves or others. and are either unwilling or unable to agree to an inpatient admission. And so a temporary detention order is executed to provide them with a safe place to be while they receive treatment and are stabilized. But there are also a significant number of individuals who are served by our behavioral health system who are actually voluntary, meaning they have a behavioral health diagnosis, they realize that they need help, and they seek treatment within a hospital through an emergency department, and they are in agreement with the inpatient admission. So we have our TDOs, and we also have our voluntary patients. And this slide here it illustrates the number of patients that are being seen throughout our system, whether they are voluntary or involuntary. And it also kind of shows the split between our private hospital admissions and our state hospital admissions. And so you'll see that for the private hospitals, the teal color for fiscal 2019, that represents 40,000 patients or discharges, those are our voluntary patients that we've admitted during the fiscal year 2019. The sky blue represents our TDOs at 18,000. And that's compared to when I talk about the TDOs, I'm specifically talking about civil TDOs, not talking about forensic, which are a population that are admitted by our state hospitals. In comparison, our state hospitals during fiscal year 2019 admitted around 5,800 civil TDOs, and then an additional amount you see there that gets them to 6,649 TDOs, and that additional amount is reflective of their forensic population. So from fiscal year 2019 to fiscal year 2021, you'll see that one of the things that has been a priority for the commission is the reduction of TDOs going to state facilities. And you'll see that that is actually happening in the most recent years. And one thing I failed to mention when I was talking about the voluntary patients is that our private hospitals admit 100% of the voluntary patients. And that is why they are such a significant amount of our behavioral health admissions. But as I was saying, the TDOs going to state facilities are slightly decreasing. And you can see this from fiscal year 2019 to fiscal year 2021. In fiscal year 2019, private hospitals were accepting around 76% of the civil TDOs. Fiscal year 2021, that number has increased slightly to 77%. And again, this has been a priority of the commission and of the state for some time now. One last slide, just to kind of, again, show the difference in admissions at the community hospitals and our state hospitals. So as I mentioned earlier, community hospitals accept 100% of voluntary patients, and the state hospitals accept the forensic patients. And just as an example, for fiscal year 2021, we accepted around 37,000 voluntary patients, and the state also admitted 700 forensic patients, which is in addition to the civil TDOs that we are both accepting. And one thing I would like to note for you all, when we have the conversations around the TDOs and the voluntary patients, a lot of times individuals believe that because someone has been admitted to the hospital under as a voluntary patient, that their clinical needs are not the same as someone under a TDO. And I have been assured by many members that that is not the case. Individuals come in different states requiring different clinical treatments and stabilization. And really, sometimes the difference simply is someone is willing to go voluntarily versus not. And so that's a very key important point that we need to understand as we're talking about the patients that need assistance or behavioral health treatment across the system. So there have been a couple of things that have impacted the decrease of TDOs going to state facilities. And that these two items here I will highlight for you. So last year during the public health emergency, there was an executive order put out that basically stated that if a state-operated psychiatric hospital was operating at 100% of their total bed capacity, they would not agree to serve as a facility of temporary detention for patients who are not under an emergency custody order. So that policy has continued. And if an individual comes into the emergency department, let's say by a family member, a friend, or on their own, not brought in by law enforcement, so they're not under an ECO, they're evaluated and it's determined that they do meet criteria for a TDO. That specific type of TDO would no longer be admitted to the state facility. So they're requiring the ECO proceed the TDO in order for them to accept the patient. And that, as you can imagine, has an impact on the number of TDOs that are being accepted by the state facilities. The other piece is happened this past summer, which was in July of 2021 when DBHDS reduced their bed capacity at 5 of their 8 state psychiatric hospitals. You all have heard about that from the commissioner as well as other stakeholders. And so we know the background around that. But as a result of that, the system lost over 250 inpatient psychiatric beds overnight. And so these two policy shifts in terms of DBHDS's admissions are having a very negative impact on downstream and the rest of the system. And so I briefly like to highlight some of the major issues that we are seeing. And so, you've heard from CSPs, law enforcement, so none of this is new to you. But in June of this year, I actually presented to the LEO ECO TDO work group that was focused on ED boarding. And at that time, I reported that our hospitals were seeing that individuals were boarding for between 4 to 8 hours and sometimes upwards of 24 hours. It wasn't happening as often, but it was happening. Now, our members are reporting that on average, a TDO patient is waiting in the emergency department between 2 to 5 days for an inpatient placement. Additionally, placements for voluntary admissions are taking as long as up to 10 days. And a lot of the issue around that, number one, is because we lost such a significant amount of beds when the state facilities halted admissions. And another piece of that is we need to ensure that we're finding an appropriate bed for the person who's presenting in the emergency department. So just because someone shows up in the emergency department and they're experiencing a behavioral health crisis and there's a behavioral health bed at a specific facility, it doesn't mean that that's the right or appropriate bed for that individual. We want to ensure that people are getting appropriate treatment and that they're safe and the other individuals that are receiving care are safe. And so there are many things that have to go into finding an appropriate bed. And several years ago, I talked about the fact that a lot of the individuals that are presenting in emergency departments are more medically complex, are more aggressive in terms of their behavior. We have more geriatric patients, those types of things. And our hospitals are beginning to shift, but have not had the time to be able to shift in such a way that will allow them to more adequately meet the needs of patients that are presenting. And so as a result, individuals are stuck in the emergency department while we are trying to find them an appropriate bed. Because of the reduction of beds from the state facilities, TDO admissions are being prioritized over voluntary patients. And so that's why you're seeing that voluntary patients are boarding for a lot longer than the TDO patients. And one last thing that I would highlight is with these long emergency department waits, we are seeing an increase in elopements or situations in which an individual has been deemed to need to meet criteria for a TDO admission, but we can't find a bed. And because the person is no longer under that 8-hour ECO period, law enforcement no longer has the authority to hold them and to keep them in custody, and law enforcement is leaving. And the hospitals do the best that they can to try to convince people to remain in the emergency department, but they're not always successful. And sometimes people do simply walk away. And in those situations, hospitals' only remedy is to contact law enforcement and ask them to bring the individual back to the hospital. So that is very concerning and something that we are seeing across our hospital systems. So I would like to turn quickly to talk about some opportunities for the future. We are very grateful for the money that was appropriated to DBHCS during the 2020 General Assembly session. And though unallotted, reallotted, we finally were made whole again at the end of that process. We were able to implement and develop 2 pilot projects that were specifically aimed at diverting admissions to state facilities. And from all reports from Commissioner Land as well as the hospital members, these programs are working well, especially the Carillion program that's been up and running, working well and are successful, and really get us to the place of creating those appropriate settings to meet the needs of the patients that we're seeing in the facilities currently. Additionally, during the summer, VHHA, on behalf of the members that you see listed here, provided or submitted several proposals for consideration by DBHCS to help appropriately divert TDOs from state facilities. The focus again on medically complex, geriatrics, aggressive patients, and some outpatient services such as PHP and IOP. So all of these facilities provided various proposals to DBHCS for consideration. And we are happy that after those proposals, DBHCS has requested $35 million in general funds in the upcoming budget to help support pilot projects for the following facilities. And you see that these facilities are representative of different parts of the Commonwealth, and they all do a little bit something different. Some are adding adult beds, some are adding PHP for mental health. Some are adding partial hospital programs, which are PHPs for substance use disorder. Some are focused on children and adolescents. And we're really hopeful that these particular proposals will be included in the governor's budget. And if not, we'll definitely be seeking assistance to try to get these pilot projects up and running or funded and then up and running, with the hope that we can get to a place of creating a system as it relates to on the hospital side, creating a system that can appropriately address the needs of the patients that they're seeing and help to reduce the boarding that we're seeing in our emergency departments, and ensure that the families and the individuals seeking care are seeking care in the most appropriate and efficient manner. And so with that, I will stop, and I'm happy to answer any questions that you all may have.
Thank you so much, Jennifer. That's the first time I've seen numbers of voluntary patients. I've heard about the issue before, voluntary admissions, but I haven't seen numbers. And those numbers go to 2019, and I'm wondering if you can produce numbers that go back to, say, 2013.
So with the assistance of our partners at DVH, yes, we can definitely do that. They actually track the TDOs. And then what we do is based on our behavioral health admissions, we kind of back into that voluntary number. But we can definitely make that information available to you as far back as they go with their information. Yes.
Yeah, I could just, as someone who's been called on to advise people in those situations, I nearly always advise people to take a voluntary admission because you don't have to stay. You can go, you can walk away from the hospital at any point. And so I don't think the people in real crisis don't ever choose to do voluntary admission, but that's just my opinion. Are there other questions for Ms. Wicker?
Mr. Chair.
Delegate Bell.
Yes, sir. I have a number of questions on the point that you just raised. And I say that because I think the statistics that have been shared with us in the past are not, they paint a different picture than what was just shared. And I'd like to go through them with Ms. Wicker to see if she has any comments. I asked Ms. Stanton, and we're all doing this at a distance, so I don't know if Ms. Stanton, have you had a chance to pull up the slides that I'm going to point to?
Yes, I have them. Which one would you like to see first?
Why don't we do the one that starts in 2015? That goes up to 2021 projected, and then we could use the second one just to show the projected numbers.
Okay, I'm going to attempt to screen share that now. One moment.
Madam, Ms. Stan, do you have the one that goes back to 2015?
Okay, it's not that one. Let me get the other one then. One moment.
And you're just talking about TDOs here, Rob. You're not talking about voluntary admissions.
That's right. Ms. Wicker made a point, and I'm not sure it's consistent with the other numbers that we have, and I want to give her a chance to comment. Okay. So, Ms. Wicker, when we look at the stats that we were provided compared to your statistics on the 3 years that you provided, there are some fairly minor differences, and that's not what I'm asking about. I assume that there are different ways to calculate its fiscal year. You have people coming in right at the beginning of the year and right at the end. They would show that what you had said is that you are currently taking, and I don't have this screen in front of me, but in the 77, 76, 77%, they have you at 74, 75. But I want to go back further because you only showed the last 3 years. And this would seem to show that the rate of overall TDOs has been relatively flat since 2015. It was just under 25, and then I guess almost 26, almost 26, almost 26, 25, 24, and then 22. But that the number of private hospital admits was plunging before COVID. And so you took 22,000 in 15, you took 19,000 in 2018, and it shrunk another 3,000 since then, or 2,900. And as a result, the number in the public hospitals has risen from 26, 23 up to almost 3 times as much by 2019. And that would not seem to be what you said in terms, I'm not saying that what you said wasn't accurate. What I'm saying is the picture was incomplete. Can you share what was happening prior to COVID such that the private hospitals were cutting the number of beds they had for TDOs as sharply as this?
Sure, I will attempt to answer your question. There are a couple of questions in there, so if I don't address all of them, just let me know. So the point of me clarifying the behavioral health admissions across the state and categorizing voluntary versus involuntary was to help illustrate that hospitals, private hospitals, are required to provide care when people come into their emergency department. And we don't have the luxury of turning someone away, whether they're voluntary or involuntary, because there's no space in the inn, basically. So what was happening prior to COVID was we were seeing behavioral health numbers in terms of voluntary increasing to the point that we were unable to accept the TDOs, and those TDOs were going to state facilities. But you will see that even though our TDO numbers were going down for a period, it was in relationship to the increased need around voluntary patients. But even with that being said, we are still taking a significant amount of patients, whether it's 75, 76, 74% of the TDOs and 100% of the voluntary patients. And so you only have so many beds that you're able to put people. And if you have someone who is seeking voluntary care and they meet the criteria for admission, we want to ensure that they're getting that care when our state facilities, because of their responsibility around taking TDOs, aren't taking any of the voluntary patients. We're taking 100% of the voluntary patients.
Mr. Chair.
I'm sorry, Delegate Bell.
Okay, I want to make sure I understand what you're saying, because I gather we'll be getting data, but the 3 years you provided shows a steady decrease in the number of voluntary admits. Are you suggesting that if we look back, we're going to see an offsetting increase before the most recent decrease?
So a couple of years ago, I provided, and I didn't bring it with me, but I provided a presentation to the SJ47 Commission subcommittee. And at that time, there was an offset in terms of the number of voluntary versus TDOs. And in fact, we were taking more patients overall, whether voluntary or involuntary. And I'm happy to get that slide for you and share that with you. But the need for voluntary the need for voluntary patients and the need for involuntary patients were increasing, and we were taking 100% of the voluntary patients. And as a result of that, that left less space available for TDOs. And I would say that now that is still the case, and individuals are boarding in the emergency department versus getting a placement in a bed. So it's not like the TDO or the crisis has evaporated. Individuals are sitting in our emergency departments right now because there are not enough beds.
Well, I think the issue for us is that I don't doubt there are some voluntary admits that have some of the same issues that are the TDOs. The TDOs obviously cannot be a TDO unless it reaches a certain threshold of severity. But if there are less serious admits that are taking up beds on a voluntary basis, and because of that you can't admit TDOs, this crisis wasn't caused by COVID. We had the meetings you're talking about preceded COVID. We could see these trend lines converging in a disastrous way. And we talked about how the private hospitals were not taking as many TDOs as they were previous, and that absent something happening, we would have a crisis, which has now occurred. I don't doubt that a non-TDO admit it's not a lockdown. I mean, as the chairman said, it's much easier to manage, and it would cover, I assume, everything from someone just about to a TDO who admitted voluntarily at the last minute to someone much less serious. But how can we, are there different ways we can parse this data? If the private hospital simply took as many private admits as they used to, we wouldn't be in the crisis that we're in.
So my response to that statement is unfortunately, comprehensively across the system, it is inadequate. And I think Senator Deeds mentioned the lack of community-based services. So I would say that if we had more community-based services throughout the Commonwealth where people could access services who were suicidal or who were, severely depressed or what have you, if there were more opportunities for individuals to be able to have basically a step down before they reached a crisis, then we definitely would be able to fill the need in terms of inpatient care. But right now, our system is such that it is inadequate, and that's why we have the Step Virginia project. That's why we have Project Bravo, because there is a realization that our system is inadequate. And basically, the only way that people can access care within our system is by reaching crisis. And I don't think that it's appropriate for the system or the hospitals or whomever to simply say to someone that because, we're glad that you are seeking behavioral health care, but because you're a voluntary patient and you're suicidal and you've come here and you're willing to seek treatment, you want to get help, you can't get help within your community. That's why you're here in the emergency department. We should turn them away and we should not provide them a bed. What I believe the system needs to do is to ensure that we have the services on the front end and the back end to ensure that people are getting preventive care, getting early intervention so that they don't hit the point of crisis, end up in the hospital, stuck in the emergency department because there is not a bed available for them, and also have a way to safely discharge people so people are not staying in the inpatient setting a day longer than is necessary. I think that, again, when we talk about voluntary and TDO patients, there is an assumption that because someone is voluntary, that they're not a danger, or because someone is a TDO, that they are, significantly violent. And what I am trying to express is that that is not the case. Individuals show up clinically the same way, and just because there is a magistrate involved, a TDO order involved, we're thinking that they should be they have a higher need than someone that's coming in voluntarily. And what I'm saying is that is not the case. And when individuals come into the emergency department, they are evaluated by professionals to determine what their clinical need is. And if they don't need an inpatient admission, they are discharged with the safety plan and those types of things. But if they do need inpatient care, then they should be able to get that care from their local hospital and not be concerned of whether or not they're a TDO or not. And the last thing that I would add is that there are situations in which, and I don't know this personally because I do not do TDO evaluations, but there have been situations in which an individual does meet criteria for a TDO, but through the work of the CSB or family or whomever, they agree to go in for treatment. So they actually end up being a voluntary patient when just before that decision, they would have been a TDO. Now, does that person not deserve the same level of care as a person that's a TDO? I would say no. And I think that the discussion that we have around us having to defend treating voluntary patients versus a TDO really takes us away from the heart of the matter, which is ensuring that we have a system that is appropriate to meet the need of anyone at any time, no matter what their need is. And our hospitals have been stepping up and have been, as they are able, taking the TDOs that are now being diverted from the state hospitals as a result of the admission closures to try to fill that gap. But unfortunately, like I said in the beginning, there are only so many beds for the amount of people that are coming through the system.
Mr. Chair,
Delegate Bell.
I don't anticipate receiving an answer that I would find satisfying, and I'm not trying to drag it out of anybody. If I could speak briefly to this.
Sure.
Nobody doubts that there are some TDOs, some voluntary admits that are just as serious as TDOs. Those include both people that get themselves there and some people that are just before the TDO takes effect, as Senator Deeds pointed out, they agree to voluntary care. But the issue here is that the numbers have been plummeting of the TDOs being accepted by the private hospitals. And we can talk and talk and talk, but there were 22,266 in 2015, 21,901 in 2016, 21,454 in 2017, 19,578 in 2018, 18,556 in 2019, 17,990. And these, you can look at it as part of the COVID, or you can look at it separate from COVID. Either way, the number of TDOs being accepted by the local hospitals has been falling now for 1, 2, 3, 4, whatever that is, 5 or 6 years. And we keep saying there's going to be a crisis. We're worried about it. This is a terrible trend line. Something's going wrong. And here we are. And even within the COVID numbers that were shared by Ms. Wicker, we see fewer overall admits from 58 to 57 to 54 over that period. So the total admits is down and the number of TDOs is down. And we can pretend that there is some solution to this other than the private hospitals, just going back to the numbers they used to take. We're not saying more. We're not saying fix our problem for us. We're not even saying adjust for inflation and growth of population. We're saying if you took the number that you took in 2016, we would have lots of issues with the mental health system, including better community care and all the issues that were raised by Ms. Wicker. But at least we wouldn't have the issue of people waiting 5 days in the emergency room, or the public hospitals being closed because they're being taken up with these TDO admits. And so I appreciate her comments and I appreciate her commentary today. Thank you, Mr. Chair.
Thank you, Delegate Bell. Are there other questions for Jennifer Wicker? Well, Commissioner Land, you're next.
Mr. Chairman, I'm sorry.
I'm sorry, Delegate Watts.
While what Delegate Bell has said is absolutely spot on as far as the numbers, as we follow this, I would like to have the total usage of beds, because I too have the hope that part of this crisis is because of the stigma being lifted and more people are voluntarily using psychiatric services in a timely way. So I want to make sure that we're properly identifying the problem. Is it absolute lack of beds because we have a larger population when you put everything together, or is it that there is this shift in where TDOs end up?
Yeah, and I appreciate your perspective, Delegate Watts. And I was going to ask Commissioner Lands for us to, because I don't think we've ever had numbers related to how many voluntary admissions are being made. And we're relying on the numbers coming from you, Jennifer Wicker. I mean, but I'd appreciate it if Commissioner Land could break down for us the number of people that are admitted to the public hospitals and give us, say, 6 or 8 years worth of voluntary admits to the state hospitals, state psychiatric hospitals, volunteer admits v forensic, v TDO, so we can know exactly how people are being admitted and we see what the trends are. Not only an increase in the number of TDO admissions, but have there been significant numbers of voluntary admits that have been declined? I think the data is the only way we can really evaluate what we have.
Happy to work to get that for you, certainly.
Okay, and Commissioner Land, unless there are more questions for Jennifer Wicker, I think you're next on the agenda to give us an update on the state of the public hospitals, and I appreciate you being here.
Thank you, sir. So good afternoon, Chairman Deeds and other members of the commission, and thanks again for having me here today. And we're going to focus on the items that you actually requested for discussion. I know we have limited time. So next slide, or first slide. So this will be an update on the bed census issues that we're facing, what the staffing efforts at the state facilities have been, and what the outcome is turning into. We're also going to talk a little bit about the crisis system transformation that we're undergoing, and then some of our priorities for the upcoming biennium. So next, let's go 2 slides, Heidi. So first up is the bed census. And so this slide is going to provide a quick update on the current status of the bed census at our 9 state hospitals. And we have been struggling over the last several weeks with some COVID-19 cases as the Delta variant surged in the community. We never did have to close to admissions from a COVID outbreak, but we did have several units in some of our facilities on quarantine, particularly at Piedmont Geriatric Hospital and Northern Virginia Mental Health Institute. We tragically did lose a staff member at Central State Hospital during this most recent surge. I'm relieved now that I can report that our COVID positive staff and patients dropped over 20 cases last week. So that was just wonderful for us, but we're still working aggressively to prevent infections and of course are having to remain vigilant. I wanted to give an update on our vaccination status. 74% of our state hospital staff and 84% of our central office staff are vaccinated. But we are, again, seeing a rising census numbers. You'll see there that these are actually beds that are turning over daily. So most of these facilities, other than Piedmont, which has the quarantine units, and Northern Virginia, which has some beds offline for ligature resistance issues, are hitting 100% throughout the day. So these numbers change daily, if not hourly, as people are brought in and discharged. So we are seeing close to 100%. So we're at 99.1% of available capacity for our adults and 100%, as you can see there at CCCA. And it also clarifies the number of beds that are currently offline. So the blue column is what our total capacity would be if 100% of the beds were open. The purple is our current staffed capacity. And so currently we have 226 beds offline. We were able to add back in beds at both Catawba, Central State, and 5 at Western State. So we are moving towards, as we can incrementally increase the beds, we are doing that. Next slide, please, Heidi. One of the most concerning factors all along has been the number of serious injuries to staff. And all of these injuries required medical attention. Most required hospitalization. And so you can see that we have seen a good decrease. So it's working, getting the patient numbers down to where the staff are able to manage the patients has really improved. Even from the last 10 days, I've done a couple of presentations. We were at 35%, and now in just another couple of weeks of us being able to recruit and retain better staff and being able to manage the patients, it's continuing to decrease. It's still too high. I think any of the private facilities would freak out if they were seeing this many injuries to their staff. But it is such an improvement, and we're continuing to recruit, and hopefully we'll be able to eventually get to truly well-staffed and safe facilities. Next slide. But so you can see that the staffing vacancies are still not where they need to be. We have vacancies of well over 20% and up to 56% still in facilities across the Commonwealth. We all know that the direct care compensation falls well below market value. We have added in the bonuses, but it's still a hard sell when you're trying to recruit people to a low hourly rate, and they have to, rely that you really entrust that you really will give them a quarterly bonus. And so we're really looking forward to, hopefully the governor did commit to putting forward the monies in the base budget so that we can realign the staff salaries and rates of pay so that that will become a non-issue and we will be able to recruit better. We had, at the beginning of the pandemic, 1,000 state vacancies. We went up to, over the past couple of months, we were as high as 1,675. We're now down to 1,597, so we're making some progress. Of course, we are only funded to operate at 90% staffing, but so you can see there we're in the 55 to 60% in most of our facilities. At the same time, they're frequently operating at close to 100% of their bed utilization. And so we're still seeing significant, like I mentioned on the previous slide, concerns with staff and patient injuries. Next slide. One more. Okay. So I wanted to provide some additional details on the authorization and use of the one-time and ongoing funding to help with reducing the staffing crisis. The governor did authorize DBHDS to use its internal one-time revenue reserve or emergency resources of $24 million to address this staffing crisis. And so we did put forward the money to fund the bonuses for the staff, as well as to do staffing contracts for out-of-state contract staffing firm, GQR, to come in. And that was for 196 positions for 13 weeks. Those will go through the next 4 to 6 weeks because they staggered the coming on board dates. So that's really worked well. So we're really also very grateful that the General Assembly authorized $45 million in ARPA funds in the special session that will allow us to continue these direct care staff retention and recruitment bonuses for the next 3 quarters of this year through the full end of the fiscal year, until again that we can increase that compensation rate in the base budget. We also requested, and the governor authorized the use of our facility and central office end of year fiscal 21 general fund balances that were swept to be reallocated, and so that we can use those monies to also support these ongoing efforts for additional contract staff. And then we also are going to be submitting a budget request for a little over $17.5 million general fund to continue these because the 6.9 will not go very far. So we're hopeful to be able to continue the contract staffing that we need so that we can continue to open these beds up incrementally. And then we're also going to be looking at salary increases and bonuses for clinical and other key staff. So our clinical psychologists, our LCSWs, our counselors, also other key staff such as housekeeping and dietary and security staff that really without those positions, we simply could not operate. So they're equally important. Next slide, please. Wanted to give an update again on our crisis system transformation. And so the high-tech crisis call centers are really going to be, they're coming online in this next month, so in November. And so you'll see that is going to make it so that Virginians can dial 988 and be connected to mental health services. So hopefully that'll reduce 911 usage and also the law enforcement being part of the response when it's not necessary. We also, as a part of this, is the 24/7 mobile crisis. And we're continuing to support the development of these mobile crisis teams in collaboration with our CSBs. And there are approximately 75 of those teams currently. And so we do have $7 million in new state ARPA funds that are going to be designated to develop additional teams. And what we're looking for is to be able to do both child and adolescent as well as adult teams with the goal of expanding so that we can get 24 hours a day, 7 days a week services in crisis, mobile crisis. So that'll be exciting. Those are coming online. And then also the development of the crisis receiving centers. And so we're currently transforming our existing CSUs and CTACs into crisis receiving centers when necessary, or if we need to, if there are areas that need it, we can develop new full CRC sites. And so we have an RFP is out to distribute $3 million in the ARPA funding for CRCs. And so we haven't gotten to the finish line on who all those are going to be. We have the original money that's already been selected for some sites, and we'll let you know on these new sites. So that'll be exciting as well. Next slide. And so for our priorities, first off is of course going to be reducing the high state hospital census and filling our workforce gaps at those facilities. And so we're going to be investing in, as we mentioned, in those state hospital workforce needs, reducing census through targeted actions and key partnerships. Ms. Wicker talked a little bit about what some of those partnerships look like, and we're always looking to do additional partnerships. And you'll be seeing that some of our proposals, and everything is out on the DPB site. So you can see what our proposals are and some of the other things for hopefully getting better partnerships and more partnerships to bring services online in the communities. And also to implement enhanced technology for state hospitals. We want to also improve our hospital operations so that we can improve quality and throughput and maximize our revenue cycle. We want to reduce the forensics footprint in our facilities. We have a very large footprint in our facilities of forensic patients. For instance, at Eastern State Hospital, almost 75% of their population now is forensic. So that also is an issue for these civil TDOs from the Hampton Roads region, Region 5. So trying to do some of those restoration services on an outpatient basis. I know that we were approved for language to allow that. It's not really being done a lot. So we're going to be working on things to get that beefed up a little bit and get some more outpatient restoration.
Commissioner Lamb, let me interrupt you if I can for a second. You said that 75% of the population at Eastern State is now forensic?
Yes, sir.
Wow.
So it really limits some of those civil TDO beds. That's part of the reason some of those folks are in the EDs, but also we're taking them across the entire state. We're taking the next person on the wait list. So those folks in Region 5 are having to travel distances as well. It's a problem. So we're working on a lot of different things at once. It's a lot of moving parts. And then also getting discharge planning, some additional resources for helping with discharge planning in the facilities. We're looking at starting a pilot on a super utilizer program that we hope will really show great results, and we could continue on and get funding, putting forward a proposal for ongoing funding in the budget. And then step down services for patients with a primary diagnosis of dementia. We have a large population of dementia patients at the facilities, and really continuing those pilots and additional work. Those are folks that should not be at our facilities in the first place. And so finding appropriate care for them in the community and building that competence and those services and supports, that's going to be important going forward. Next slide. And then it'll come as no surprise that our other priorities are expanding those community services that are so needed and the community provider capacity solutions, and building a sustainable workforce is critical to the system, not just to our facilities, but the entire system. And then finally, many of our IT and data systems are kind of patchwork together and out of date. So we need to modernize those systems. And that concludes my presentation, and happy to answer any questions. And thanks again for inviting me.
Are there questions for Commissioner Land? Well, thank you, Commissioner. Appreciate you updating us on the hospitals and on your plans for the future.
Mr. Chairman. It's Monty.
Well, I see you, Monty, but I've got Rob Bell on my screen. Rob, did you have a question? Monty Mason, Senator Mason's got a question.
Yeah, Mr. Chair, I did not. I apologize.
No problem. Senator Mason.
Sorry about that, Mr. Chairman. I thank you, Commissioner Land. I really appreciate you pointing to the forensic population, particularly at Eastern State. Mr. Chairman, I'd like to add that over a extended 3-year period, and I don't know how COVID impacted it, but I think it is part COVID, 35 to 40% of those are there for misdemeanor competency restoration. And so it really changes the ballgame dramatically what we're trying to do.
Well, I don't understand that at all. I don't understand how that happens.
Yes, sir.
Because it doesn't seem to happen in the courts where I practice. Delegate Hope, Delegate Bell, do you all see anything like that? Misdemeanor restorations?
Yeah.
Mr. Chair, we've suggested, or we've talked about, no, that's not something I see a lot of, at least not in the courts in which I practice, that I still suspect that it is a way that the lawyers who wish to make sure somebody gets care may use it, with everybody kind of being agreeable to do a competency restoration. But I have no data for that. I've suggested that to you and to Senator Mason as a possibility to explain the interesting numbers. It's common, as you know, for people to be fairly creative in trying to find a way to get some treatment in places where there's not a mental health docket or something like that.
And Mr. Chairman, I do have one question.
Delegate Mason. Senator Mason, I apologize.
Commissioner Land, I see your priorities for the state hospitals, and obviously with the crisis we've had. What kind of priorities do you have for the CSBs on a go forward? In the last several presentations, we've heard almost no conversation about them beyond the discharge planning that we've talked about fairly regularly. What priorities do you have for them?
So we have put forward our priorities and hope that the governor will include them in his outgoing budget. They're, like I said, they're listed on the DPB website. Everybody can see those. They're all public, but it would be fully funding the other steps of the STEP Virginia, also to continue the next and work on the next phase of the Bravo. Will also impact them as well as the private providers. Lots of things. I mean, there's I think like 70 proposals that we've put out there. Many of them will impact the CSBs. Hopefully, if they get picked up, we'll see some improvement.
Yep, yes, ma'am. I guess I'm surprised that you have a priority slide for state hospitals. I guess I'm just surprised that you don't have a priority slide for this group and for us regarding the work that we're trying to focus on for the CSBs. But thank you, Mr. Chairman. Thank Commissioner Land for your presentation.
Mr. Chairman.
Delegate Price.
Yes, thank you. I think this is for Commissioner Land, but we received communication in part about like kind of the, I guess, reimbursement rates for services for children. So that aside, what was mentioned also in the communication was the long wait times for background checks to where people are choosing to go with other offers as opposed to wait for the background checks that may be happening within the mental health space. Can you talk a little bit more about that and maybe what the root cause is so that we can maybe address that as well?
So there are two elements to this. One is the background check that like DBHDS processes, but there's also a piece of it that is at DSS, Department of Social Services, which is a more in-depth one, which I think is where we're finding that the slowdown is. And we have reached out and they have put additional staff on to work on that backlog and to get that moving faster at DSS.
And was that, Mr. Chairman?
Delegate Price.
Yes, and Commissioner Land, was that more recently so that maybe the full effect of that change may not have hit just yet?
Yes, ma'am. Yes, ma'am.
Okay.
It's been in the last 2 weeks.
Okay, thank you.
Okay, are there additional questions for the commissioner? If not, we're going to Dr. Ward and Dr. Walker with an update on DMAS, on their activities, and I appreciate you all being here.
Thank you, Chairman Deeds. And I want to check with Sarah Stanton as well on our time. I'm mindful that we're, I think, past time.
I think you are fine with the presentation you planned. We should be good to go on time.
We will aim for parsimony in our presentation here. So Chairman Deeds, members of the committee, thank you so much for having Dr. Walker and myself here today to give you some updates on DMAS and our activities. And it's really only appropriate that we kick off this discussion with Project Bravo, which really lies at the intersection of all of the other presentations that you have heard today. And part of why that is that when we talk about the state psychiatric bed crisis census and we acknowledge that we need to boost community services, that is not just about access to the current services. One of the core issues that we have is that the current array of services that we have is not comprehensive enough, particularly within Medicaid. So there is this piece that Project Bravo brings to this this puzzle that we are putting together, which enhances the services and builds out those different stair steps in the system. So I know it's been a while since we've talked about Project Bravo, so I just wanted to kind of loop in how it fits into this conversation. Defining new services, enhancing services with more fair rates to make them more accessible, and better rates and services that include licensed mental health professionals are two ways to attract and incentivize the use of licensed mental health professionals in our system. So there's the piece about building out services, kind of if you build it, they will come type idea. And then there is the workforce. And that fabulous presentation of data earlier today has just been such a long time coming. Really understanding where those holes lie is central to putting together the pieces of the puzzle here. One thing to keep in mind when you look at that data is looking at DHP data, basically, around who is licensed and in these roles. One thing I want us all to keep in mind is that the number of providers out of those numbers that you saw today who are enrolled and participating providers in Medicaid is a fraction of that. Right? And that's that hat we have to have on, because part of the puzzle is drawing those licensed providers back into a public mental health system that they abandoned decades ago. Many of the providers out there who are licensed work in a fee-for-service system where they take cash. That's the system that most people with some level of privilege, that's how they access mental health care. They don't even go through commercial insurance. And so really, part of this workforce puzzle is thinking about how we draw in licensed mental health professionals perhaps early in their career around a lot of those incentive programs we've discussed, to kind of have them build their chops early in their careers in the public mental health system. And that's where a lot of other states have drawn strength. So we're going to talk a little bit about that as I update you on Project Bravo and where we're at in that effort. So, overall, just remembering Project Bravo is this vision to build a high quality Medicaid behavioral health continuum that draws from the evidence base, from what we know works, that is trauma informed, and is the best use of the public monies to which we are entrusted at DMAS. Next slide. This is the famous purple cliff. This is the former continuum. Well, really our current continuum is represented here, where we have our community mental health and rehab services, which are very intensive, having this kind of cliff that drops off to the other levels of care. Next slide. The idea of Bravo is to build out this stair step that can do what the other speakers today have discussed needing, which is being able to step down and out of that reliance on acute inpatient care. It's hard for people to jump off that cliff to get to other services. What we need is a kind of equalized stair step to help people move from level of care all the way down into a recovery or maintenance phase. Next slide. An important acknowledgement as well off of Senator Mason's question about the CSBs and their role in this picture is that the foundational Step Virginia start to all of this work is really where this sprung out of. But the idea is that what we've invested in Step Virginia is impacting that CSB system, where only about 20% of our Medicaid behavioral health members participate in care. And we've been monitoring that number. That number has stayed relatively the same throughout COVID, where about 20% of our members, of course, a little variation across different services, but the large proportion of Medicaid members participate outside of there. So how do we take the kind of principles and values of access to care in Step Virginia and the CSBs into that public system? And importantly, during a workforce crisis, how do we leverage the workforce that is sitting outside the CSBs to help us improve access to care for these quality services? And so Project Bravo is kind of that big idea of how do we build out the Medicaid system as a whole. And the first 6 services that we were given authority to move forward with is what I'm going to update you on today. Next slide. So we are very happy to report that in July of this year, we went live with 3 new services. Those were assertive community treatment, mental health partial hospitalization, and mental health intensive outpatient services. As a reminder, of course, these are all services aimed directly and kind of methodologically to address the psychiatric bed crisis. So there's good evidence to indicate that these would shake things up a little bit. Now, of course, all these hypotheses were made prior to the onset of the COVID pandemic. And so that is a confounding variable. I think we're all very interested in understanding how these services will play out versus how they were planned to play out, given that they're rolling out in a lot of really different ways, in some ways, a lot more flexible ways than previously planned. But they are also rolling out during a workforce crisis that has worsened during the pandemic. And so in some ways, I have tempered my expectations personally and tried to do that with our stakeholders, because even though we are opening up these new services, there's only so much you can do when there isn't the workforce to provide them. We're only as powerful as the workforce that we employ. So we are currently very engaged in the standing up of our next set of services, which go live in December. That includes multi-systemic therapy and functional family therapy, as well as the crisis transformed services that Allison Land spoke of earlier. These set of services are, in our minds, extremely critical to the bed crisis. When we talk about avoiding the need to go into that ER and become boarded there, it really is about meeting people in their natural environments. It's about the infrastructure provided through 988 and through triage, through that call line and text lines, being able to really figure out what response is needed and basically strategically using our limited workforce towards intervening in person with the people who need it most. Next slide. So the intent of these services that went live on July 1st was really to beef up assertive community treatment, increase the rate to one that was going to sustain these programs and support fidelity to the model, really just prop up something that was already working well but need to be paid better. This was going to build that level of care step and allow for kind of either diversion from hospitalization or a step down option. And it was also going to utilize both our licensed and unlicensed workforce, which is critical during this crisis. Now, the impacts are yet to be fully felt. Obviously, we're only 3 months out. I would love to be here presenting data on this and what our utilization looks like, but we're going to give a preview of what we will be able to present when Dr. Walker jumps in on the conversation later. So in the current time, what we know is the services are being used. Next slide. So there is some initial success. One of the successes we're all feeling together is that DMAS, DBHDS, and all of our stakeholders, we actually pulled this off in a pandemic and a workforce crisis on a extremely limited timeline from our homes. We never thought that was possible, but it is live. And we've had really unprecedented collaboration because we have suddenly been able to use WebEx and all of these online Zoom rooms that we didn't have access to. So now, I can talk to 7 CSBs within an hour. I can have them all gathered in a room, which would have been impossible before. So it really has strengthened, at least for our teams, the relationship with stakeholders and the flexibility and just kind of ability to get on the ground and talk with people about how things are going. So we have successfully enrolled 41 ACT teams. There's 1 new team brought online at Fairfax CSB, as well as 4 new MHIOP programs and 52 new PHP programs. So that is great news. We know that there are others, particularly PHP and IOP programs that are in development and that will hopefully be enrolling over the course of the year. And they're just kind of setting up their business models. So we are seeing utilization, but of course that takes time to kind of really show up in our system given lags. So we're looking forward to watching that. We've learned a lot of big lessons as well. One thing that we've learned is moving towards this higher quality of care requiring accreditation or Medicare certification is a big step for some of our providers. And so we learned that we really needed to listen to them about what their needs were. We set up meetings, kind of trainings with the accrediting bodies for them so that they could get more information and put out a bunch of informational brochures and things to the providers to help them in that process. And those were very successful and well attended. We've also learned that even though we can all embrace this spirit of reducing duplication and wasted worker time, and we can all think that is great, it is harder than we think to reduce those things. And they are often embedded across multiple agencies' regulations, and there are discrepancies. And so we have to work really closely in coordination with the other agencies to assure that if one of us changes something, we all change it. And so there aren't conflicts. And we had one of those tension points come up around the individualized service plan with ACT. But I actually consider this a real success in that these types of snags and implementation are inevitable. And when this one came up, where basically we changed something to make it more flexible for providers, but it was in conflict with the DBHD regulation, the CSBs actually quickly picked up on this, contacted us. We did numerous meetings with them, worked out solutions that were agreeable to everyone, came up with a short and long-term plan, and put everything into place. And I think that it helped us to plan for future snags and how we can work together swiftly to get them resolved. We've done a ton of individual consultation with providers. It's been really helpful. And again, that's been helpful to leverage the Zoom and WebEx technology to reach people quickly. Biggest lesson, don't give up, even when there's a global pandemic. And there are many naysayers who say it can't be done. As the saying goes, don't say it can't be done to the person who is doing it. So we've pulled off this first step. So next slide. Again, we are working on a really complicated implementation here because this is the intersection of Project Bravo, where we're creating and defining these new services and how they will be paid. But it's in the context of a crisis system that will be for all, not just for Medicaid members. And so that involves rolling in the Marcus Alert legislation, how this intervenes with emergency services and code mandated services, TDO reimbursement, STEP Virginia crisis work, and then the 988 legislation. So, it's taking all of our focus and patience to really try to pull these things together to set the foundation for a crisis system that I think will be building, for the next decade together in terms of building out the network and perfecting how that infrastructure directs and dispatches all of the providers as those networks grow. Next slide. We've made really good progress. I won't hang here long, but wanted to demonstrate that we are well on our way. Our state plan was submitted. We're excitedly meeting with CMS tomorrow morning early at 9 a.m. to address their very minimal questions on our SPA. So we are working on the finalization of dashboards, which I think is of particular good news and interest. I know that there are many data-oriented folk on this committee, and I believe that Delegate Bell is going to be a big fan of the dashboards, and I can't wait for him to see them. So Lauren Walker is going to be here to talk about some of the dashboards we have up now and what we have planned to be available to improve the transparency of our data. We have many things in progress right now that are coming to fruition in the next few weeks, including all of the systems changes and 5-hour-long meetings with the MCOs to test all of those systems, our training for hundreds and hundreds of providers. So it's a very exciting time. Next slide. The biggest question that I have been asked in every Zoom room that I enter is where we go next as a system and where we want to go as a Project Bravo team. And so our answer as a coordinated team at this point is this. Number one, we only have authority to do what we have been working on. And so all of our energy has gone there. But there are clear system priorities that have surfaced throughout this experience of the pandemic that I think were there before, and they're included in our continuum proposal, but perhaps have been clarified through the impacts of the pandemic. So one of those is fairly obviously youth services. There's a lot of concern about what happened when schools were out, what schools are experiencing now with students coming back in, the impacts on therapeutic day treatment and access to that level of care, what is happening in the free care space with the allowance that went in last year for schools to bill outside of the IEP and operationalizing that. What is that going to do? There's, great interest in expanding reimbursement for evidence-based practices that could be used in schools and implementation of high-fidelity wraparound and coordinated specialty care for young adults with psychosis, with first break psychosis. So these ideas that have kind of always been there have been underscored by the pandemic, the need to really look into these youth services. And then in terms of integrated care, the pandemic has really shown all of us that the relationship between physical and behavioral health is undeniable. It is completely intertwined, and the need to have behavioral health professionals integrated into physical health settings is very important. And so the Virginia Mental Health Access Program has been a step forward, but how can we bring actual providers into those settings and not just the referral connections? There's also been a lot of close looking, through the Joint Commission on Health around long-term care and the integration of behavioral health for our aging population. Some data shows up to 50% of geriatric patients in those settings have behavioral health needs. So how can we meet people in the physical health settings where they are living to kind of provide these types of supports for whole person health. So these are some of the conversations we've had about some kind of obvious priorities that we think most stakeholders agree with and have agreed with. But next slide. We also are mindful, as many of us are clinicians, of systems and humans' capacity for change. And this has been a very difficult couple of years on the existing workforce. And to be honest, those of us on the state workforce who have been implementing these services. And so there's, a real recognition that just plowing forward and continuing to plow into services and ask so much of the system can do more harm than good. And that we need to take some breaks in this implementation to assure that we're moving forward in a way that is planful, that reflects kind of a collaborative spirit, that we're all on the same page about what we're working on. What we learned with Bravo is having all the stakeholders pretty much together on this has helped us to move forward without a lot of opposition and being able to move swiftly. And we need to have that in the future as we bring on new priorities. So, right now, our thoughts are about really pricing out what any of these other options would cost the Commonwealth so that we can make wise financial decisions about, where to put our investment in the house that we're trying to build together for behavioral health. Next slide. Other really brief program updates. I know the therapeutic day treatment remains on many minds, including my own. We continue to monitor it. This is a snapshot of one of our internal dashboards where we have seen that the services continue to struggle because even though schools are open, they are not necessarily open to having additional staff. It's very complicated with quarantine and not having kids get outside of their kind of potted classrooms. So it's continued to be a thorn in the side of the provider community not being able to provide that service the way they once did. I designed and created a training back in July. There's a recording of that training on the website where I kind of broke down what we know about the impacts of the pandemic on children from a clinical perspective and the implications that bears for the services they may need upon return to school. That was highly attended and is still available. And that was at the request of stakeholders to kind of provide some insight into what DMAS is looking for as people reemerge into the schools. Next slide. A few more quick things. The Support Act grant are terrific workforce efforts that we've had through the CMS grant. We received a no-cost extension that due to the disruption of the pandemic that will allow us to do these activities for another 6 months, all the workforce development stuff that we've been working on. However, we were not granted the demonstration grant portion. So our participation in the Support Act grant will end at that time. We have been working on our telehealth supplement, much anticipated. We had a overview we did for stakeholders, which is available on our website. Our supplement was just up for public comment and came down. We know that there's still a lot of questions remaining, and we're dancing a fine line between kind of the finalization of that supplement and what will happen when the end of the public health emergency at the federal level will happen, which will guide when we pull down some of our flexibilities around telehealth with maintaining what we believe is a generous amount of them to maintain the access of care that is enabled. Coming soon, hopefully very, very soon, is the launch of our RFP for our behavioral health service authorization vendor. That's connected to our Medicaid enterprise system implementation. So that is very exciting that is coming out. And we continue to be building our new website and adding basically all of our public meetings, our trainings, our webinars, everything is loaded to YouTube and linked to our site. And so that has proven to be a really excellent resource for stakeholders. And that is where I'm going to hand this Zoom microphone over to Dr. Walker to speak about some of the efforts that her team has worked on in intersection with my team, but really carry the weight on interpreting Medicaid data and dashboarding it for greater public transparency. So, Dr. Walker.
Thank you, Dr. Ward. I'm Lauren Walker. I'm the Senior Advisor for Health Economics and Economic Policy at DMAS, and I've been working with Alyssa's team on putting together some tools for you all that we think is going to be very helpful on our website in terms of our behavioral health data. So I'm just going to give a brief update on how you can find some of these tools. And I'm going to do a very brief demonstration because I am cognizant of time here, so that you all can see what types of resources we've now have available. So in addition to where all of the trainings are on the website that Dr. Ward was just mentioning, we have now created a new behavioral health data webpage. So this is just from our main website where the data tab here is. There's now an entire behavioral health section that has all of these various different resources on here. I will navigate that for you, and then I'm going to give you a brief demonstration of one of our dashboards specifically. But I just wanted to go through a few things because some of them do require a few clicks. And so for time's sake, I'm going to flip through some of these stagnantly. But what we've really focused on here is putting together resources that include quality measures and other types of managed care oversight activities so that you all can find everything in one place. We will continue to add to this site as we continue this work here. But at the moment, we've really focused on different types of reports and dashboards related to quality measures. So this is just the output that you will see when you navigate those different resources that I just showed there on the right. These are 3 specific reports. So here on the left, you see the Virginia Medicaid Managed Care Behavioral Health HEDIS reports. So we have put together in one place a table of all of the outcome measures associated with behavioral health quality measures. So our HEDIS scores, these are national quality measures that all of our managed care organizations are required to submit to us annually. And then we aggregate everything as a state, and then we are compared against the national percentiles. So you will see on most of these, we actually perform above the national average. But as you go through, and this is just a snapshot, there are many others on that website, you will see that for the most part that we are actually performing above average in most of these quality measures. And then on the right here, these are just a few other reports that I want to call your attention to that are available. One is the Performance Withhold Program. So this is a value-based purchasing program that includes, among other measures, multiple behavioral health service measures. And so this area on this webpage, you can go to the Performance Withhold section, and you can find more details on those specific measures and the outcomes. And they are both in CCC Plus program as well as in our Medallion 4 program. The measures vary slightly between the 2 programs. And then the last one here that I want to call your attention to before I do a quick demo is the Foster Care Report. This is a report that is conducted annually by our external quality review organization. And it's a report that's really targeted for our foster care population, but our comparator population in the report is actually all children. So this is a really excellent resource if you're looking for outcomes and quality measures among our children. And while there is a foster care focus on it, it actually provides information of our entire Medicaid children. And specifically, there are 9 different behavioral health quality measures included in there, as well as an additional 3 substance use disorder measures. And these largely include ADHD, but it also includes follow-up measures from emergency departments, as well as hospitalizations. And so this is just I'm going to click here to take us to our quick demo. So one of the dashboards that we've included here, give that a second to pop up, is our provider adequacy. So as Dr. Ward mentioned, the numbers here are going to look slightly different than what Debbie Oswald was presenting earlier, and that's because these are just the providers that are specifically enrolled in Medicaid. But here again, so just so you can orient yourself to the website, main DMAS web page, you click data, behavioral health, and then you have all of these different items that you can use. This one is the network adequacy report. And so this is a dashboard that we've set up, and I'm going to just blow it up just a little bit for you. Hope that's big enough. Where you can click on the different plans. So we have right now, I've selected for the entire Medicaid program. But if you were interested, for instance, if you had a constituent specifically in one plan, this is an area where you could look at a specific plan if you wanted to. And then we have a series of provider types. And I'll just scroll down here so you can see the different options. So this includes, this includes arts providers, but it also includes CMHRS, and outpatient providers, psychiatric hospitals, and psychiatry. So again, I'll click through that in a second, but I want to give you a demonstration for all the providers. All right, so right now I am selected on all of the different types of arts providers. I could click through and select specific types of arts providers. And I'm going to just decrease this so you can see a little bit better than that. And so here, if you scroll over an individual area, so for instance, this is Culpeper, you can see that the total number of providers, Culpeper, the total number of providers here, this is again for arts providers, is 10.5 providers per 100,000 members. So one of the things that we thought was really important to add to this dashboard was our number of members, because oftentimes if I were just to do this by number of providers, you would see similar to in Debbie's presentation, there's a large number of providers in Fairfax County, but we also have a really large number of members in Fairfax County. So one of the things that we did here is, yes, you can get the total number of providers here. As you see in Culpeper, there's 111, but we've also adjusted it by the population in that area, so you can get a sense of adequacy in that area. And so this again, just you can click through. Please feel free to play with it. I'm happy to answer questions if anybody has specific areas that they would like to look at. And then I'm just going to show one other quick item here. I'm going to click through to our coming soon dashboard. So in that same area, you will see another dashboard pop up soon. So it's going to be in that same list of resources. So everything is together in a one-stop shop. The other dashboard that we're working on right now, and this is really with an emphasis on all of the services that are going to be offered in Project Bravo, but also our current continuum of care, so we can start to monitor and see where there might be shifts in how utilization is, and it shifts in utilization. And so for this dashboard, we're really focused on two different things. The first set is going to be overall, what are the services that are being used and what are the expenditures in that area? And so as you can see here on the left side, you can select by time period. You'll be able to select whether you want to look at managed care or fee for service, and then you can select by diagnosis or age of the person. So if you're looking for children's services versus adult services. And that will give you total utilization, number of members that are using the services, and it will also give you expenditures. And then the last part here, which we're very excited about, is really being able to break down more granularly the demographic information. So here we'd be able to look specifically at carefully as our menu options have changed. And then we'd also be able to look at gender, age groups, race, ethnicity, and then primary diagnosis. So what are the types of services that somebody with a specific diagnosis is actually using? So this is our next dashboard that we'll be adding to that same list of resources, but we are hopeful that these tools are useful for you all in your planning purposes.
Thank you so much. Dr. Walker, a couple of months ago, the Senate Finance Committee met in Abington, and we were talking about the rollout of the Medicaid benefit, adult benefit for dental services, and the effect that reimbursement had on limiting the number of people, the number of providers who would sign up. Has there been any sort of analysis of the reimbursement rate for behavioral health specialists, and what impact raising that would have on our ability to attract providers to Medicaid?
Sure, I will start, and then I bet Dr. Ward has some additional input.
Okay.
Most of that is looking at our rate studies. So we do have an actuary that we work with who has implemented many of these services in other parts of the country. And so one of the things that they look at is specifically what is an adequate rate to get the resources that you need into your state. So that is part of the rate studies that we do before implementing any of these services. And Dr. Ward, I know you have a budget package, so I will let you speak to that if there's anything else you wanted to add.
No, that's a great answer, Dr. Walker. I mean, essentially the rate study looks at where the current services are, what they are offering, how many members would be kind of eligible or relevant given our population for those certain services, so they can do a bit of prediction about what the utilization might be of that particular service and how many providers they think would come on board. It's not necessarily specific to what you're asking about, like, if we raise the rate to this, who could we pull in? I've never seen analysis specific to that. I mean, I think the global null hypothesis is if you pay people, they will come. And that right now the rates are insufficient. I mean, we've certainly seen at least a demonstration that by, improving the rates and proposing them, there has been, it's drummed a lot of interest in the new services.
Is a rate study ongoing, or has one been done recently? Will there be any recommendations for increasing rates in the next budget?
That is going to be our request, that we are able to kind of rate study the whole package. So all of the different services that were in the original continuum proposal and, get a sense of what investment, the Commonwealth has priorities around at this time. Because it's hard to, without knowing how much something is going to cost, it's hard to weigh one choice over the other. In terms of where to strategically pick. I've been likening it to HGTV. It's like if you don't know how much the bathroom will cost versus the kitchen, it's hard to choose between them. So that's really what we want to provide to stakeholders and legislators and the administration is a better data-oriented view of what it would cost for these different services, given our population and what we have in Virginia.
Okay, thank you very much. Are the questions for Dr. Walker or Dr. Ward? Delegate Watts.
Thank you, Mr. Chairman. A question for Dr. Ward back on slide 13. If I heard you correctly, you made the comment as you brought up the challenges in youth services that that was beyond your authority in setting up Bravo. Did I hear correctly?
We were given authority to move forward with these 6 specific services, Delegate Watts. So when I speak of our authority, just meaning in order for us to change anything about the service, its rate, its medical necessity criteria, we have to have the authority of the General Assembly. So we have the authority to do the 6 we have, but for example, making changes to school-based services or therapeutic day treatment would require us submitting a budget decision package or having a bill come through.
Follow up, Mr. Chairman.
Delegate Watts.
What concerns me in all of the outline slides before that, there wasn't really references to working with the school system. That an entree point either through the CSBs, yes, but a specific component of this that makes sure that we have the right entry points for those who are identified through schools, which I hope we will manpower available, be able to have far more serious counselors available so that we can do not just preventative, but certainly when you get up to middle school and high school, that tracking of those individuals that counselors are dealing with and funneling them into the serious services that they may need as opposed to just the contact with the counselor is a very major need that we have, that the family services come into the system in a different way. But the individual student, that does not necessarily encompass an individual student's problem that may need to be brought into the system with or without the family structure being necessarily involved.
Delegate Watts, I think you're absolutely right. I think one of our biggest concerns going into transformation of school-based services is the the absolute need to have really intense coordination with DOE, with the localities, the superintendents, and the private providers that have so far been dominating the service provision in schools through TDT. So this is a really a delicate conversation around how we meet the needs of the children using the combined workforce of school employees, CSB, and private provider contractors who help the schools, because their needs are always going to be far beyond what they are resourced to do. And so there's a lot of examples of how that's been done in other states when free care has been lifted. There are national learning collaboratives around the design of those programs to assure that all 4 tiers of the multi-tiered systems of support are set up in a way, like you're saying, to identify who needs preventive services, to screen, to assure that, the kids who need family intervention get it, and the kids who can be worked with, just at school receive those services. So it is a complex equation that will require significant teamwork with the school systems individually, as well as DOE.
Thank you, Mr. Chairman. I like that answer. I just hope that it is reflected in the previous 12 slides of what you really are doing as far as this kind of coordination.
Mm-hmm. Thank you, Delegate Watson. And we seek to continue that collaboration with them.
Okay. Are there other questions?
Mr. Chairman.
Senator Mason.
Could I follow up on that? Thank you, Mr. Chairman. Dr. Ward, is that verbiage sounds very similar to all the work we've done over the past few years with the Family First effort. Is that a place that we can piggyback off services that once we get more in the clearinghouse? Is there a match there, or am I off on that?
There certainly is. And I think that one of the things that has come out of COVID that has been one of the biggest strengths is that the child serving agencies, including DOE, have worked together more closely than reportedly ever before. In that we all had to communicate and be on the ground together very early. We're meeting at least once a week, and now have an ongoing meeting where we all meet just to check on status. That coordination has also been brought together through our Center for Evidence-Based Partnerships that we have formed with VCU as kind of our center part of the wheel. And all of the DOE has been at the table throughout. And really the goal of all of that has been to align the work happening with Family First in terms of the services in the EBPs that are being endorsed and chosen by the state, and what, for example, DJJ already brought on and has paid for out of their transformation, what DOE has attempted to implement, and to make sure that as funders of these services, we're defining them similarly, we're considering the workforce issues similarly, because there are different workforce considerations in who provides this through DJJ versus the folks that are licensed to provide these services in schools. That's a whole other subtlety issue, but really the goal is to make sure that we are all defining the same things, that we're paying equitably so that there is an incentive to move to one funder or another. And as Medicaid stands in a regulatory sense, we're the payer of first resort. So we're always going to pay first for the kids who are members. And so that we need to work really closely with these other agencies like DOE, like DSS, to assure that we're all on the same page, so that we can pay for the services and pull down our match for those kids. And so it's this can't be done without all of the agencies at the table together and in a kind of constant problem solving mode to assure that, because ultimately we need to leverage every member of that workforce who is in every one of those sectors, who's in the school, who's in a doctor's office, who's working for DJJ. They all have to be at the table for us to bring success, particularly around youth services.
Did that answer your question, Senator Mason?
Well, thank you. And Mr. Chairman, that just points out, hopefully we'll see in the governor's budget an emphasis on this Center for Evidence-Based Practices that Dr. Ward just mentioned, because although she weaves in and out of all of these different services and complexities with ease, it is impossible for the layman to follow. And that may be a great center to try to bring so many spokes to the middle of the wheel. So I hope we'll be on the lookout for that this year. Thank you, Mr. Chairman.
I knew, we hadn't heard anything from Dr. Ward for months, and I knew that we would all appreciate an update on Bravo and where we are with Medicaid. Are there additional questions? If not, as I said, we're not going to have we don't have anything to vote on at this meeting, but now we are going to take public comment, and my understanding is we have some people that want to be heard. Do we have people in the room?
So, Mr. Chair, what I would do is ask those people who are in the waiting room if they would like to speak to raise their hand, and I will bring them into the room. Currently, we have 2 hands up, sir. We have Anna Mendez. I'm going to bring her into the room. And after that will be Jennifer Spangler.
Okay. Are we ready with Ms. Mendez then?
She should be in the room now. So when you get a chance, Ms. Mendez, go ahead and unmute and speak.
And I'd appreciate it if you could hold it to three minutes, Ms. Mendez.
Absolutely. Hello, Chairman Deeds and members of the Behavioral Health Commission. I am here to speak with you about something that was not mentioned in today's meeting, which is that Partner for Mental Health has helped catalyze having the CDC recognize that mental illness is a risk factor for morbidity and mortality due to COVID. This happened on Friday after a months-long effort that we helped lead. And our engagement on this issue was in response to a very local need. A homeless services provider is using the high-risk list to determine eligibility for shelter. And that's why we started. But throughout this months-long process, what has happened is that the CDC has released guidelines around the need for boosters and people for COVID vaccination boosters, and people that have conditions that are on the high-risk list need to be getting boosters. And thanks to the efforts of lots of advocates, this now includes people with some mental health conditions. So I have sent all the members of the Behavioral Health Commission an email with this update, with an infographic from the CDC. And I'm just asking you to please share this widely with your constituents. It was an amazing amount of hard work that went into making this happen. And we need to spread the word widely across Virginia, because if Virginians that live with mental illness and the people who care about them don't know, then people aren't going to get boosters. So thank you for helping us spread the word.
Well, thank you for your work and your advocacy, Ms. Mendez. Jennifer Spangler, are you there?
I'm here.
Okay, please go ahead.
Good afternoon, Chairman Deeds and Commission members. My name is Jennifer Spangler. As you know, I live with bipolar disorder, which is regarded as a serious mental illness, or SMI. Last month, I shared that 3 decades of research says the link between mental illness and violence is weak and indirect, and that an SMI diagnosis is not a predictor of violence. Today, I will discuss how that stigma affects people with SMI. First, here's what I suggest to ensure stigma doesn't steer public policy. First, reach out to constituents and ask them about their experiences in your CSBs, in your private provider psychiatric units, and state hospitals if you have them in your district. Second, hire a stigma expert. Third, expand the 988 education campaign to include an anti-stigma campaign directed by a stigma expert. Here are some stigma facts. Stigma has been steadily increasing in the United States since 1996. Currently, 75% of the public believe that a person with SMI is dangerous. 83% believe mental health system failure to identify dangerous individuals is to blame for mass shootings. Because of these, the public believes that the most restrictive form of treatment, involuntary hospitalization, is best. This is public stigma. Public stigma can lead to structural stigma. One pathway to structural stigma is using public stigma of dangerousness as a method to gain approval for increased spending on mental health. This increases, 1, the use of legally ordered preventative detention, 2, the use of legally ordered adherence to treatment in the community, 3, denial of civil rights, and 4, loosening standards for public reporting of protected health information. Here are 2 more facts. Virginia, according to Mental Health America's 2021 ranking, is 47th in the nation for adult access to mental health services. And 70% of young adults view involuntary hospitalization, which they experience negatively, and thus lose trust in adults and providers. Virginia's behavioral health system is failing not because people with mental illness are refusing care. It is failing because treatment is viewed negatively and preferred community treatment does not exist or is inaccessible. You may know that I was given this year's VACSB Gartland Award. Senator Gartland, you all may also know, in his retirement speech, quoted Edmund Burke, who said, "A representative owes his constituency not his industry only, but his judgment, and he betrays instead of serves his people if he sacrifices that judgment to their opinion. 3 out of 4 of your constituents falsely believe I am dangerous because I have SMI. Please exercise judgment of their opinion and carefully examine the impact of public stigma before you change and create laws to avoid the devastating effects of structural stigma on people who live with serious mental illness." Thank you.
Thank you, ma'am. Thank you for your advocacy.
Mr. Chair, we do have one other person, Emily Griffey. And if I can ask if there's anybody else in the waiting room who would like to speak, if you can go ahead and raise your hand now, I will get you into the room. But we do have Emily Griffey.
Ms. Griffey.
Well, good afternoon, Senator Deeds and members of the commission. Just wanted to thank you all for taking some time to look more specifically at youth mental health needs today with those questions that were raised by Dr. Ward, by Delegate Watson, by Senator Mason this afternoon. I also circulated a paper to many of you to look at the intersections between the education system, the Medicaid system, and our Department of Behavioral Health and Community Services so that we can better address children's mental health needs and student mental health needs holistically. As Dr. Ward mentioned, this is really going to be a delicate balance. This is going to take some additional work and getting folks at the table to sort through these issues. I think that your role on the Behavioral Health Commission can help provide leadership there. I think the governor's office and the future administration can provide leadership with the way that the children's cabinet is set up and the way to work across systems like the Department of Education and Human Services. And I think that there will be work to do to really iron out those steps in the continuum that Dr. Ward pointed out that meet the needs of students that are identified as meeting by students as meeting their needs, and that are identified by professionals in the field as the best fit for meeting student needs within the school settings and community settings. So I encourage you to take some time to do some of that hard work this year with the commission, with your partners in state agencies, and to encourage the next administration to make this a priority of looking across those different agencies as well. And finally, I also encourage you to hear from students and young people themselves about what they want from their providers in this space, who provides them the support, who helps keep them on track. And so I hope that you'll also hear from students themselves in developing these solutions.
Thank you, Ms. Griffey. Appreciate your advocacy. MJ?
Mr. Chair, that we do not have any more hands raised.
Now, didn't we have some op-ed shared with us earlier, and somebody said that they were going to want to?
Mr. Chair, you did have an op-ed shared with you earlier from somebody who indicated they were planning to speak, but I have, I'm not sure if they've actually.
Well, then, is there anybody else that has anything for the good of the order?
Mr. Chair?
Delegate Price.
Yeah, thank you. I heard the comments that were shared and really taking into account, especially the, I guess, learning curve that we might have on stigma and choosing our words carefully. So I want to definitely say I heard that. But in addition to that, hearing that Ms. Spangler wanted to connect stigma education to the 988 education campaign. Dealing with that connection separately, I did want to know if we could get an update on the 988 education campaign, and then secondarily to see how we might be able to connect some of that like public education about stigma to it as well.
Well, I don't know if anybody can address 988 now, but we can certainly get that information either provided to us individually or at the next meeting. But I'd prefer to have it provided to us soon.
Yeah, exactly, Mr. Chair, because whatever we can do in our leadership roles to help encourage the education, and so people know when it's going live, that it's going live, would love to play a part in that. So at our next meeting, an email, but would love an update.
Well, I think with respect to stigma, we all have to remember that people are watching all of us, especially those of us with small children. They pay a lot of attention to us, and the words we use all the time make a difference. And it's important for us to be very careful about the words we choose to use. But Sarah, I would appreciate it if you could get a 988 update and get that out to us by email. Is there anything else? Well, thank you very much for your time and attention this afternoon. We're adjourned.